Have I been dead?
Sorry.
Have I been muted all along?
Let's go back.
Holy Moses, I've just found out that I've been muted all along, so I have to start all over. All right. The topic of discussion, as you all know today, is IVF failure with good quality embryos. I think it's a very important topic because many, many people go through IVF repeatedly and are unable to achieve pregnancies, and without an explanation. I'm sure most of you realize that it's not that there's no explanation, it's just that it's not been diagnosed. And it cannot always be diagnosed, but best effort must always be made to try to determine why that's the case. This is one of many seminars that I hold through the web, and I ask you to which one do I push to go on? I ask you to bear in mind that there'll be about a 20 to 30 minute presentation, followed by a question and answer session, and you can start posting your questions from this point on anytime you like. If you want to submit additional questions, you can go to forums.haveababy.com, forums.haveababy.com, and post them on the SRM Las Vegas discussion board or the SRM St. Louis discussion board, and I will address them as soon as I get to them. Or if you choose, as many of you already do, go to my blog, ivfauthority.com, post any questions or issues there, and I'll be sure to address them. You can, if you choose, schedule a consultation with me anytime. It'll be via Skype. I only hold consultations at a distance via Skype, and you should call me at 800-780-7437, speak to Shelby, and set up the consultation with her. You may also want to visit our website, haveababy.com, where you can get a lot of additional information. So let's get going straight away with the topic again, which is IVF failure with good embryos. To start with, let me put it in perspective. We see about an increase in the success rates of IVF. We've seen them over the last decade or more. Looking back to the year 2000, for women under the age of 39 years, the baby rate with IVF was about 28% per procedure, but now it's up to almost 40% already. There have been significant improvements in the field, enhancements. Some of these have involved more recently the introduction of genetic testing to prove that the embryos of competency, that they have good quality, and others have involved some of the changes that people are now adopting more and more in the field of dealing with implantation dysfunction. You all know that my interest lies specifically in the arena of immunologic implantation dysfunction, which will be part of this discussion today. I go back to the basic concept to understand what causes success or failure, or put it differently, to be able to address unexplained IVF failure. You first have to understand what is needed to make IVF work. And you know, it's a very simple concept. I like to call it the soil-seed relationship. Only here, the seed is the embryo, not the seed you plant, and the soil is the uterine lining. Obviously, you can't plant a good seed in a bad soil and expect a healthy outcome, just as you can't plant a bad seed in a good soil and expect a healthy outcome. And it is the variables that affect the quality of the seed, its competency, in other words, and the receptivity of the uterine lining that will determine success, with one additional factor to boot, and that is how you plant the seed. In other words, in this case, the technology, the technique, the expertise used, the delicacy in the approach to embryo transfer. It is important to know that by and large, most times women fail to conceive. 70% of the time, it's going to be due to an embryo issue, the seed. And 30% of the time, roughly, could be a little more or a little less, the cause of failure is going to be the failure of the embryo to properly attach to the wall of the uterus. And we'll be discussing these as I go along. Now, let's look firstly at then, here it is again, the three predominating factors that are necessary to have a good IVF outcome, and the areas where things can go wrong, leading to IVF failure. The first one again, the egg or the embryo's quality. And I say egg embryo because in most cases, the embryo's quality is very much determined by the egg rather than the sperm. And then there's the technique of embryo transfer and the factors that affect the ability of an embryo to attach, or uterine receptivity. Let's talk first about the egg embryo quality. 2 points to make. There are overriding factors that affect the potential of any egg to be able to propagate upon fertilization a healthy embryo. The first of these factors is the age of the egg provider, of the woman. It's important to understand, and you'll see it as I go along a little further, a little later on, that young women under the age of 34 years, roughly 1 out of every 2 eggs are going to be normal and of good quality. And a normal egg will propagate a healthy embryo that will almost always go to blastocyst, probably in about 80% of cases. But the egg has to be normal and has to be competent, and you're going to find out that that ability resides primarily, but not exclusively, in the egg's chromosomal makeup and its integrity. So age is a big factor, because while up to the age of 34, roughly 1 in every 2 eggs is normal. At 40, maybe 1 in 5 or 6 are normal. And when you get to 45, alas, only about 1 in 20 eggs is going to be normal. Obviously, if it's abnormal, it will always propagate an abnormal embryo. And an abnormal embryo, as I've pointed out, 70% of the time is the cause of a failed pregnancy or a repeated miscarriage, whether it be a natural pregnancy or an IVF pregnancy. The second factor is the environment in which those embryos in the uterus have to survive. And you have to, sorry, let me say that wrong, is the environment in which the eggs in the ovaries have to develop. It's extremely important to know that one of the most important factors in successful IVF outcome is the method used for ovarian stimulation. But in most things of life, any biological occurrence occurs in a bell-shaped curve fashion. We call it a Gaussian distribution. What that means is that 70% of people their eggs will develop normally and adequately regardless of the protocol of stimulation you use. These are usually young women in their mid to early 30s or younger, and women who have got normal ovarian reserve, meaning that they've got lots of eggs and will respond well to fertility drugs. Outside of this bell that comprises 70%, there are a group of women that don't respond typically because of an abnormal, or shall I say, an out of the ordinary ovarian environment. The ovaries comprise of 2 compartments: follicles that house the egg inside, and they consist of the connective tissue surrounding the follicles. The follicle that houses the egg also produces estrogen, and it produces the estrogen in response to a hormone produced by the connective tissue that surrounds the follicles, known as the stroma or the theca. And from here, under the influence of the hormone LH, from the woman's pituitary gland, her own LH, or the LH administered in drugs, there will be production of testosterone. And this testosterone is carried like in a bucket brigade fashion to the cells that line the follicle, where it is converted under the influence of the hormone FSH, the sister hormone of LH. It will be converted to estradiol or estrogen. In the process, the cells that line the follicle multiply, the follicle stretches, fluid builds up inside of it, and more estrogen is pumped into the circulation. And in the same process, the egg that is adherent to the inner wall of the follicle undergoes developmental changes to prepare it for its final process of maturing, which takes place with the LH surge in natural cycles, or when HCG is given as a shot to trigger maturation of the egg during the last 36 to 40 hours of the ovarian cycle. You must have, therefore, a little bit of LH to make a little bit of testosterone to be carried to the follicle so FSH can convert it to estradiol, the follicle can grow properly, and the egg can develop optimally. Too much testosterone is like a flood on a garden instead of a gentle drizzle. And what it will do is it will cause it'll get into the fluid of the follicle, compromise the cells that line the ovarian follicles, the granulosa cells. They'll become exhausted. It will build up in the fluid and it will compromise the development of the egg. So now when you come to that point where the egg has to mature and has to develop into a mature egg in 36 to 40 hours after the HCG administration or the LH surge, it will mature, be more likely to mature abnormally. And that is why as women get older, and they've got a build-up or thickening of that area around the follicle that produces testosterone, and very often the LH production is increased, and therefore the ovarian testosterone production is increased, they end up having poor quality eggs. Eggs that look normal, but that is up to the point of the trigger, but then when you give the HCG, the eggs don't develop normally, they don't go through their normal maturational process. They end up with chromosomal abnormalities that we call aneuploidy, which is the root of all evil, as you'll see in a few minutes later. So older women who've got diminished ovarian reserve, and some women who've got polycystic ovaries tend to have an overgrowth of this area called the stroma or the theca that produces testosterone, and excessive production of biologically active LH. So they're at risk, and in these women more than in any else, you have to use a very individualized protocol of ovarian stimulation associated with down-regulating or suppressing LH and testosterone before the cycle and during the cycle of stimulation to protect the eggs from these adverse effects that I've just spoken about. This is very important, and we'll touch on that maybe later on in the question and answer session. You cannot use a one-size-fits-all approach to stimulating women for IVF. You've got to use an individualized protocol that takes into account their individual characteristics that can be assessed by testing before you go into the cycle. Here's an ovary that has been stimulated. These are the follicles that you see here, and it's the cells that line these follicles, the granulosa cells that produce the estrogen. It's the connective tissue between the follicles here. In these walls, that is the stroma or the theca that produces the testosterone in response to LH, carried to the granulosa cells adjacent, and then the granulosa cells, by the action of FSH, produce estrogen, which gets to the circulation. And of course we measure the growth of the follicle by its increasing and expanding size, and by ultrasound, therefore, and by the measurement of estradiol in the blood. Obviously we put a needle into these follicles and exact a suction pressure to get the egg out, and that egg is then fertilized. This is what the egg looks like when it's mature. I'll explain this in greater detail, but you notice the shell around it, the zona pellucida, and this little nubbin on the end, which is the polar body. This polar body is what happens in the maturational process after the HCG or the LH surge, when the chromosomes in that egg divide in half, and half of it is extruded into this area below the outside development, or the zona pellucida, and it's called a polar body. What should be left in the egg to make the egg mature and normal is exactly half the number of chromosomes that were present 36 hours earlier, which means from 46 down to 23. So that when the sperm comes along with 23 chromosomes, it can fuse with the egg and now produce an embryo that has the normal genotype, human genotype of 46 chromosomes. In this little envelopment, this polar body, which is really going to be destroyed and disintegrate and disappear within a few days, there is half the chromosomes, or there should be. Believe me, it is in this 36-hour period that things go wrong, where the number of chromosomes, instead of dividing from 46 to 23, divide to less than or more than 23. And such an egg will have more chromosomes or less chromosomes in the spolar body than are left in the inside of the egg itself. And such an egg is aneuploid. It has an irregular number of chromosomes, and if it fertilizes, it will invariably produce an embryo that's also aneuploid, and such an embryo cannot propagate a viable pregnancy. And that is the reason why we see, with increasing age, an increased risk of this egg aneuploidy, and therefore embryos of poorer quality, even if they look normal. And such embryos will not make a baby that is a normal, healthy baby. They'll either not attach, or they won't, or they'll miscarry or be lost in early pregnancy as a chemical pregnancy. And rarely, if they do take, they'll take and produce an abnormality like Down syndrome. All of these things are more likely to occur as women get older for that very reason. Here the egg is being injected with a single sperm by the process we call ICSI. We do ICSI virtually in all of our IVF patients. We don't charge for it because we believe it's the right way to do things. It's the best possible way of achieving fertilization. And if you do ICSI in cases of non-male infertility, there's no evidence whatsoever that it has any deleterious effect. When it comes to male infertility, there's really no other choice. You have to do ICSI, and you have to live with some of the consequences, which can be chromosomal deletional factors in the resulting embryo, increased risk of miscarriage, and of course also because many forms of male infertility are carried on the Y chromosome. Male offspring of men with infertility, where ICSI was done, very often can expect to have a child with a greater chance of having male infertility in later life himself. This is a good quality day 3 embryo. You can see there are about 8 cells here. They're equi-sized. There are very few fragments. The zona pellucida is still around the surface of the embryo. This is a day 3 embryo. The next one I want to show you is a blastocyst. This is an embryo that usually reaches this stage, if it's going to get there, by day 5. But it can take 6 days, and that doesn't necessarily mean that the blastocyst can't make a good, healthy baby. But this area of the blastocyst here, the inner cell mass, is where the baby's formed from, and the inside area here is what's going to make the fluid in the sac, and the cells around the outside here, known as the trophectoderm. These cells are simply the cells that are going to form the membranes and the placenta in the offspring. I want to make a point early and repeat it again later because it's so important. I can't say this more stressfully enough. I can't stress it enough, sorry. Not stressfully enough. And that is that embryos that do not divide in the laboratory to this stage by day 6 are almost always, in more than 90% of cases, aneuploid, chromosomally abnormal, and thus incapable of propagating a healthy, normal baby. So you don't want them. And who are we kidding by putting them back earlier? I used to think, just like everybody else used to think, and many still do, that to put an embryo back sooner into a natural environment benefits it. But it does not. Our own research has shown clearly that if an embryo tested for CGH by CGH on day 3 is normal, then those are the embryos that in 82% or more cases will make blastocysts. But if the embryo is chromosomally abnormal, the blastocyst conversion rate is probably no more than about 25%. And those embryos that don't make it to blastocyst always are chromosomally abnormal. That doesn't mean that those that make it to blastocyst are chromosomally normal. They're just the ones that are most likely or more likely to be. And because many of the abnormal ones are culled out along the way, you have less embryos to consider as candidates for transfer if you wait for the blastocyst stage of development. So in the old days, and I mean 10 years ago, we didn't really know much about the genetic makeup of embryos. The only tests available to determine the chromosomes of an embryo was a PGD test known as FISH, or fluorescence in situ hybridization, which didn't look at all the chromosomes in the embryo. It only looked at some of them. And therefore it was very unreliable in telling you whether the embryo was normal. It could pick up certain chromosomal abnormalities that cause miscarriages and birth defects and help you correct for those. But it could not tell you which one was normal. And what we had to rely on was microscopic evaluation of the embryo's characteristics. So we'd all look under the microscope. We all thought we were so smart. And I was no exception to the rule. In the year 2000, I introduced the graduated embryo scoring system, a better form of a mousetrap. And all we were doing there was trying to look at the developmental stages of the embryo and attach a score at it. Not much different to what you see happening in some of these new video technologies where they look at an embryo going through its development and therefore try to assess whether that embryo is more or less likely to be a good one. But the GES, or Graduated Embryo Scoring System, allowed us to take bites at certain stages after fertilization to tell if the embryo was more or less likely to be normal, and it worked. It was a little better than most other regular microscopic grading systems, but it certainly didn't prove to be all we'd hoped to. The system I'm not going to go into now was measuring 1 and 2 and 3 days after fertilization, and we looked for certain changes inside the embryo, attaching scores to it, and at the end of the day, when you added them all up over 3 days, it was the score you reached out of 100 that told you whether that graduated embryo score was likely to be associated with a good quality baby, a good quality embryo. This shows you what we saw. If the score was between 70 to 100, about 50% of the time that we put in 2 or more embryos in those days, 2 or more embryos into the uterus, we'd get a pregnancy. If it was under 65, it was about half that. It was a good morphologic assessment of embryo quality, but not nearly as good as what we can do today, because given what I've told you before, the rate limiting factor in human reproduction is whether the embryo resulting from fertilization of an egg with a sperm has all 46 chromosomes, 23 from the male, 23 from the female. And if that embryo has more or less than 26, that will mean that embryo is incompetent. And an incompetent embryo either will stop dividing and arrest, or it won't attach to the uterine wall, or it'll attach and be lost through an early pregnancy loss, miscarriage, or whatever. So it is, again, the integrity of the embryo. Although the sperm plays a role, it is largely the chromosomal makeup of the egg, not the sperm, that will determine whether the embryo will end up being normal. If there's severe male infertility, then the sperm tends to contribute more, but by and large, in the absence of severe male infertility, the egg factor plays a role predominantly, which is about 90% of what an embryo turns out to be will be derived from the egg rather than the sperm. This just shows the chromosomes in the egg going through the process of division. I told you that it's a ripening division. We call it meiosis, or reproductive division, which separates the chromosomes in half and sends half of them out of the egg into that space just below the shell of the egg, or the zona, as a polar body, leaving the reciprocal amount, the mirror image, inside the egg. So it was that in the middle of this last decade, we got hung up on using a test that had been used and developed in other fields of medicine, known as CGH, or comparative genomic hybridization, to try and measure all the chromosomes inside the embryo, so that we'd know which embryo had all 46 chromosomes. So CGH is a test that can do that. There are many forms of CGH. The two that are widely used, the one we use because we prefer to do the test as close as possible to fertilization, because we believe that the closer you are to this meiosis process, the more you'll be picking up abnormalities that are due to abnormalities in the meiosis, rather than in the subsequent division after fertilization, where the cell numbers just replicate, and of course chromosomal abnormalities can occur there as well. But we find that the earlier you do it, the more likely you are to pick up those abnormalities that are not reversible. Whereas abnormalities that occur after meiosis, we call them mitotic aneuploidy. That means with a regular cell replication after the embryo has been formed, that occurs from the 2 to 4 cell stage all the way up to the 150 cell stage, at the blastocyst stage. That is when you measure the blastocyst, you're picking up many abnormalities that might have occurred as a consequence of mitosis. We think the earlier you do it, the more likely it is to be meaningful. And so we do a process known as metaphase CGH on day 3, and it's a very safe procedure, highly specific and sensitive, and there are not many places in the world that do this because it's very expensive to do. And that's why we tend to send our DNA, not the embryos, but the DNA that we take out at a biopsy, we tend to send it out of the country to a laboratory we've established in Europe that can do it for much less. Otherwise, you have to do something called array CGH. And in my opinion, array CGH is not that reliable when you have to measure the minute amount of DNA present in a single cell. And that is why when you do array CGH, you're far better off, in my opinion, doing it at the blastocyst stage, where you can lob off 5 or 6 cells, pool all the DNA together and get a better idea of what the embryo is like. If it shows you that the embryo is abnormal, it's highly reliable. If it shows you the embryo is normal, it's highly reliable. Just as reliable as metaphase CGH. But we believe that if it shows you the embryo is abnormal, you may often be picking up something we call mosaicism, which is due to aneuploidy caused by the mitotic replication of cells. And you could possibly get falsely positive or falsely abnormal results. There is no data that I can use to verify this fact. We are trying to put some together, but at the moment, that is just an impression. That is just my personal opinion, and why we prefer to use metaphase CGH on day 3 than using array CGH on day 5 or 6. But what I personally do not, in my opinion, believe is right is to use array CGH routinely on day 3 embryos. If you're going to do it, you need to do it array CGH on the blastocyst. As I say, a normal embryo is normal, whether it's array CGH on the blastocyst or metaphase CGH done on the day 3 embryo. Again, how do we do this? We take a biopsy. We just remove a single cell from the embryo, aspirate it, and then that cell, the DNA from that cell, is then sent for CGH analysis. Here you've got 4 embryos. Here you've got 4 embryos that look beautiful. In fact, they're even hatching out of their shells. Nobody in the world could look at these 4 embryos and tell you anything more or anything less than they look exemplary, perfect. Yet, the interesting thing is that when we did CGH, we found that 2 were normal, these 2, but the next 2 were both aneuploid or abnormal, even though they looked good. And what that's telling you is that beauty is in the eye of the beholder. It shows you how wrong you can be when you look under a microscope, because the embryo could be abnormal and look perfect. So using CGH analysis, we're able to pick up the embryos that are normal, and if we put even a single embryo that is a blastocyst, and that CGH normal into the uterus, into a uterus that is receptive or rendered receptive through treatment, such an embryo will have better than a 60% chance of propagating a pregnancy. So CGH doesn't make better embryos, but it identifies those that are normal and those that are abnormal, and allows you to put them back selectively, put back fewer and avoid the risk of multiple births, and also get healthier babies that are far less likely to have chromosomal abnormalities at birth, and of course reduces the miscarriage rate almost tenfold, because most miscarriages are also due to chromosomal abnormalities of the embryo. The second issue is the next point I wanted to mention, and that's, by the way, from what I've told you, there are two things to take away from the first section on the embryo, the seed. The quality of the seed is influenced by the age of the woman and by the method of ovarian stimulation used. If you use a recipe size or one size fits all approach to women who fall in the bell where they've got normal ovarian reserve and they're younger, you will do fine. But if you use sometimes the same approaches in women outside the bell that are older, that have diminished reserve or polycystic ovarian syndrome, you can compromise the eggs and thereby the embryos and thereby the outcome. Well, now to embryo transfer. I don't want to spend a lot of time here, just to say that learning how to do embryo transfer is fundamentally a rate-limiting factor in IVF. Most programs that train doctors in the IVF arena don't allow their fellows to do many embryo transfers. They know that that's where things can go wrong, even if the embryos were perfect. If you don't transfer them delicately and properly into the right place, you will lose the opportunity to give that person a pregnancy. And they are quite right. So embryo transfer is a very, very important process. Firstly, I believe, and that's my opinion, that we in this day and age should be transferring blastocysts. There's no point in transferring an embryo earlier when you know that if you give it an extra couple of days and it doesn't make it a blastocyst, it was abnormal anyway. And if it makes it to blastocyst, it's more likely to be normal. So that's the first point. Secondly, in this day and age, transferring a single embryo or perhaps two blastocysts is about as far as I'm prepared to go. I think that today we can freeze embryos so safely through an ultra-rapid freezing method known as vitrification, which hardly affects them, their viability, their survivability upon the freeze thaw, and you can keep them indefinitely, and when you thaw them, they're usually just as healthy as they were the day they were frozen. So why go putting back large numbers of embryos and taking the risk of propagating multiple births? So putting back up to 2 blastocysts, but not more than 2, is my own philosophy, and those of many others as well, fortunately. Do you do a mock embryo transfer before the cycle? Many people do. I don't. I think you can map out the course of the cervix. You can see under ultrasound exactly where to place the embryo. There's no need to go sticking catheters into the uterus before the transfer or before the cycle and possibly introducing infection. It is important to have the bladder full only because of 2 reasons. Filling the bladder flattens the uterus that's in the wrong position, pointing upwards. We call that anteverted. It'll flatten it and make it easier for you to get the catheter in and see where you're going. And visualization is critical. So you must fill the bladder to the point that you can see, or let water out to the point that you can see the inner stripe of the uterus best. And then you've got to transfer it under ultrasound guidance. In this day and age, in my opinion, there's absolutely no excuse for non-ultrasound guided transfers. Placing the embryo in the mid-portion of the uterus, and delicately so, under careful ultrasound evaluation, is the best way to go. I said there are 2 reasons why you want a full bladder. One is for visualization, but the second reason for filling the bladder is that there's a reflex suppression of the nerves that cause the uterus to contract, and so could expel the embryo from the uterus. Therefore, a full bladder is conducive to a more relaxed uterus. This is just a slide to show you an embryo placed right in the middle of the uterine cavity. There's the lining of the uterus, and this itself, that little spot, translucent spot there that fluoresces slightly, that is the embryo placed in the right position. The next issue to talk about, and the final one, is the third important component to a successful IVF, and that is uterine receptivity. Now, you need to understand that you cannot plant a good seed in a bad soil. You cannot, because if you do, it won't take. And so it is that there are 3 factors there are many, many more. But the most important 90% of the time, 3 factors that will determine success or failure of a good embryo to implant, giving you a receptive lining, are 3 things. The first is how thick that lining is and what its appearance is under ultrasound. And in 1989, I published a paper published in Human Reproduction. We were among the first to show that a lining less than 8 millimeters will not easily sustain a pregnancy. Between 8 and 9 millimeters on the day of the HCG shot is good, is okay, but it's not ideal. Over 9 is excellent. So we look for a lining of greater than 9 millimeters, but thicker than 8. Under 8, I don't do a transfer in that cycle. And the second issue is the immunologic receptivity of the uterus, which I'll come to in a moment. And the last one then, or in different order, no matter how these slides come out, whether there are any surface lesions in the uterus which can create a reaction that would reject the embryo. So first, let's look. I've gone to the last one first, typical of me. So the last one is, this shows you a sonohysterogram where we've injected water into the uterus before we went to the IVF cycle. And here you can see in that uterus, this little area here, which is a polyp. That will make it far more difficult for an embryo to attach. It's got to be removed, and it's removed hysteroscopically usually, but it can also be removed by a DNC polypectomy. Here's that same polyp, and it's not a very good picture, I apologize, but this is the polyp looked at through a hysteroscope. So you see it there, you go behind it, like a mushroom, you find its stem, you clip it off and remove the polyp, and everything's fine. But that polyp would not make it easy for an embryo to be able to find proper implantation potential in that uterus. The second issue is the thickness of the uterine lining that I told you. These are one of my very old slides. I actually made these slides in the 90s. You'll see here that this lining is only 5.8 millimeters thick, and it's done on the day of the HCG shot. That lining will not support a pregnancy, in my opinion, and is a contraindication to doing an implantation in my way of thinking. Here's an excellent lining. It measures more than 9 millimeters. It's 11.3 millimeters, and it has the typical trilaminar or 3-layer appearance. Notice the whiter outer border of the outside of the lining, and then when the 2 layers come into apposition, flat against one another, creating the third lining. This is the third layer. This is a trilaminar 11 millimeter lining, which is an excellent lining, and the uterus itself also looks normal. So what causes you to have a poor lining? Well, the commonest and the most dangerous cause is a totally damaged and destroyed uterine lining endometrium from infection, which usually follows a pregnancy, either a miscarriage or the birth of a baby, or a molar pregnancy, or an abortion where some of the products are left behind. These products are dead tissue, and the bacteria from the vagina ascend into the uterus. They grow in the uterus, and they destroy that basal layer of the endometrium, that layer that I told you on the inside, from which the new lining forms every month. When that happens, often scarring occurs between the layers or the walls of the uterus. We call that an Asherman syndrome, often associated with reduction in menstrual flow or absence of menstrual flow. But whether or not there is scarring visible inside the uterus or not, if the basal or the germinal inner layer of the uterine lining has been damaged by such infection, in my experience, in few cases will you reverse that with any treatment. Doing a DNC, scraping the uterus, removing any scar tissue sometimes can help, but in most cases it's very unrewarding. These women are often left with a permanent problem that drives them to either stop or to consider using someone else to carry their babies. It's worth trying treatment that you'll hear of in a moment with Viagra and estrogen, but it usually won't help. Another one is a condition where the glands in the lining of the uterus grow in like seaweed into the wall of the uterus and disturb its blood flow. And in those cases, the uterus the blood flow to the lining is reduced, and if it's reduced in association with this condition called adenomyosis, these types of linings often do respond to Viagra vaginal therapy. In the same way, if a woman's got multiple fibroids all over the uterine wall, compromising the delivery of blood to the uterine lining, you again can have a terribly poor response to estrogen. And in those cases, removing the fibroids may help. And if not, then certainly trying to improve the blood flow again with estrogen, antiprostaglandin medications like ibuprofen or aspirin or indomethacin, and Viagra may help. And then there is the one that is really sad. When women are placed on clomiphene citrate repeatedly for more than 3 cycles. Clomiphene is a fertility drug, but it's also an anti-estrogen. It thins the lining, it builds up in her system, and renders the lining thin because it can't respond to estrogen, given the anti-estrogenic effects of Clomid. The good news is that you stop the clomiphene for 1 full month or up to 6 weeks, then the lining can recover and it can develop properly again. And then there is the big one, which is related to age. The older the woman gets, vascular changes in the uterine blood flow can reduce delivery of estrogen to the lining. Here again, Viagra and possibly antiprostaglandins and estrogen can help. I'm not going into how this works, but vaginal Viagra simply increases blood flow to the uterus, so it delivers more of your own estrogen or administered estrogen to the lining, making the uterine lining develop better. And I've seen in 48 to 72 hours a lining, I saw today in fact, in a patient who had a lining of 5 millimeters, and in 72 hours of vaginal Viagra, 4 times a day at 25 milligrams a day with specially prepared suppositories or pessaries, I saw a woman go from that to a 9 millimeter lining in that short period of time. It works extremely well. Okay, now the last one is one that evokes the most controversy, but I'm going to say this and stick my neck out here. In my opinion, the naysayers are getting fewer because of the new technologies of treatment that are emerging that are no longer expensive and are safe, like the use of intralipid. And I believe, and we'll see if I'm right, 5 years from now, this is going to be the new frontier in IVF. How to deal with immunologic factors that reject the embryo's attachment to the uterine lining. I'm seeing it already by speaking to my friends who own laboratories that do the tests for immunology. They're overrun with demand. They can't cope anymore and try to find a place that will be able to easily give you intralipid today. It's hard to find because it's in such demand, they're running out. Even the doctors that tell you they don't treat immunologic problems are treating them. And for those that are not, very often the patients come to those of us that are for that very treatment. Now, there was a time when the treatment we used for severe immune implantation problems required the use of a blood product called IVIG. And IVIG is a blood product, and nobody likes the idea of using blood products in an era where HIV and hepatitis C are rampant. So I don't blame people for being frightened of it. Besides, IVIG did cause side effects in 25% of women that used them, and it was horrendously expensive. 2 infusions of IVIG could cost as much as an IVF cycle, and it certainly didn't guarantee a baby because it didn't influence embryo quality. It only improved the soil, not the seed. So for those reasons, doctors were understandably concerned about telling patients to take a treatment which other doctors would decry, often because they didn't understand properly what it involved, and they'd lose their patients to the guy down the road who said, "I don't believe it." The truth is, folks, thousands of babies are being born because of immunotherapy done selectively in IVF for those people that need it. There are cells in the uterine lining known as natural killer cells that journey to the uterine lining from the bone marrow every month, and they proliferate under the effect of estrogen in the first few weeks of the cycle. They probably are responsible for regulating proper implantation of the roots of the normal embryo into the wall of the uterus. And they do this through a push-pull mechanism of releasing growth factors that attract the roots and others that cull down the cells in the roots, so that the embryo that the root system that will eventually form a placenta will be confined to the inner aspect of the uterus and come out easily after the birth of the baby, and also be an excellent exchange mechanism for the baby to the mother. Everybody must have natural killer cells, and we wouldn't be having this webinar if your mothers didn't have good working or well working natural killer cells, and mine, hopefully. Some would argue that my moms maybe weren't that good, and that's why I'm a little bit crazy. But the truth of the matter is, you've got to have natural killer cells that function. And so it is that these natural killer cells can go wrong. They can, under certain provocations, and some of them are genetic, some of them are due to other immune disorders present within the body, and we'll talk about that later, start to produce too much Th1 cytokine, which is that factor that kills off cells in the roots of the embryo. If they overproduce that, they will either wipe out the embryo before you even know you're pregnant. You'll think you're infertile and you're not getting pregnant with good quality embryos, where in reality you're losing the pregnancy before you knew you were pregnant. In other cases, they'll damage the roots of the embryo, and the embryo limps along and eventually runs out of steam and you miscarry. And in worse situations, the embryo can survive and go on to form a poor placenta that can't feed the baby properly. The baby doesn't develop as normally and healthily as it can, and we get other problems in later pregnancies, such as intrauterine growth retardation, placental separation or abruption, and other things. So unexplained intrauterine death, or whatever it may be, because suddenly the baby runs out of steam. The first variety of causes for immunologic natural killer cell activation is when it is your body reacting to its own tissues. We call that autoimmune. This one here is responsible for the vast majority, almost 80% plus, of all immunologic causes of failure to implant. And so autoimmune causes with natural killer cell activation are by far the commonest cause, immunologic cause of IVF failure with good embryos. In those cases, all we need to do is downregulate them today using that substance I said, intralipid, and that intralipid will calm down the natural killer cells. You give 2 infusions, and instead of costing $3,500 or more a pop, it costs $150 at most, and you do it twice. There are no side effects, no risks. Intralipid is so innocuous that now some doctors are even going so far as saying, why don't we just give it to everybody, just in case? And that's also wrong, because you've got to give it differently for different causes of the problem. Here are a few examples of why the autoimmune factors can eventually cause failure for implantation. A family or personal history of immune diseases like lupus, rheumatoid arthritis, or hypothyroidism or hyperthyroidism are often associated with activated natural killer cells. In fact, I published on the fact that women who've got thyroid antibodies, thyroglobulin, microsomal antibodies, or thyroid peroxidase antibodies, have a 50-50 chance of having activated natural killer cells. And if you don't deal with that, your chances of a successful pregnancy are tremendously reduced. Endometriosis, very, very common. No matter how severe or mild it may be, 1/3 of women who have that condition will have activated natural killer cells. I don't want to go into detail on the alloimmune causes. If you want to read up on this aspect, autoimmune and alloimmune causes, where the woman and the man have too many genetic similarities provoking the natural killer cells to become activated, I urge you to go to my blog, ivfauthority.com, and read the 2 articles I wrote in May of 2011 on immunologic implantation dysfunction. Again, www.ivfauthority.com, and look for 2 articles on immunologic implantation dysfunction that I posted in May of 2011. Let's go quickly. How do I go back here? I went this one. Okay. This simply shows again how 85% of the time the natural killer cells are activated. It's an autoimmune implantation dysfunction. And only in 15% of cases will it be due to an alloimmune cause. Now remember, only one in four women who have who are infertile will have an immunologic problem. 3 in 4 will not. So the bottom line is we're talking about a small percentage, 25%, of which 85% of the time, and in that 25% so affected, it'll be autoimmune, and that's easily and readily, completely eliminated with intralipid and steroid therapy. In 15% of the 25% of cases, it'll be alloimmune due to similarities genetically between genes called DQ alpha and HLA. And these are more difficult to treat, but they are treatable, and you can help people solve that problem. Treatment with intralipid, and the treatment is with intralipid and with steroids combined. It's no good giving intralipid alone. You've got to combine with steroids, and the intralipid has to be infused 10 to 14 days before the embryos are transferred. And the dexamethasone, prednisone, starts at the beginning of the cycle and is continued until pregnancy is discounted or the woman gets the 10th week of pregnancy. IVIG, I've mentioned, I no longer, hardly ever, if ever, give IVIG, and I was a strong proponent. I don't use aspirin, although the very first paper I published on immunotherapy in IVF included aspirin. I've since found that I was wrong. I don't think aspirin helps. I think it thins the blood and increases the risk that when you put the catheter in the uterus to transfer the embryo, you'll cause unobserved bleeding that will prevent implantation. Heparin and Lovenox Clexane. Heparin is short-acting. Lovenox Clexane are long-acting. These are very helpful in cases where the woman's got a lot of antiphospholipid antibodies or certain types of hereditary clotting defects is called thrombophilia. And then the last one is LIT therapy and Humira. Well, this leukocyte immunization therapy is not legal in America any longer, so it's not worth discussing. And I'm not a fan of Humira because I know that you do need some activity of your Th1 cytokines. You need some of that activity to get the embryo to start implanting. And if you take Humira, you may knock it out to such an extent that it prevents implantation. Now, Humira might be able to be used when the woman's already pregnant and threatening to miscarry and has an immune problem. Once implantation's already occurred, perhaps Humira can then be used. What are the indications for testing for immunology? Firstly, unexplained IVF failures with good embryos. Here it is. Unexplained infertility, where you don't know the cause. Recurrent pregnancy loss, where it's very often due to an immune cause. Autoimmune diseases in your family or person, such as lupus, rheumatoid arthritis, and hypothyroidism, and the presence of any degree of endometriosis, because in such cases, 1/3 of women will, or 30% of women will have the problem. So that really basically concludes this presentation. I apologize for going so long, but I think it was worthwhile. And for your questions, I'll be happy to take them now. I'll just look and see whether we have any questions already listed. Where are we? We'll start at the beginning first. So here we go. Where's the first one? I can't see it very well. Just bear with me a second. Why don't you enlarge it up there? There, yes. Enlarge that. Okay. So let's start right at the beginning. We're still not at the beginning. Enlarge it. Go down. We'll have to take them as they come. Kimberly Geiger writes, do abnormal eggs typically make it to the blastocyst stage? Kimberly, I mentioned that abnormal eggs will make abnormal embryos, and only 15 to 25% of abnormal embryos will go to blastocyst. It doesn't mean that because an embryo makes blastocyst, it is normal, but if it doesn't, then the embryo is almost always aneuploid. The second question comes from Cardina. Using donor eggs, that's you, Cardina, and you've done array CGH in each, but you've failed. Boy, oh boy, an implantation factor is high on the list of possibilities. Somebody needs to look inside your uterus by doing a sonohysterogram or a hysteroscopy, and you need to check the thickness of your lining during the cycle. Was it over 9 millimeters? And you need to do the immune tests, starting with natural killer cell activation. If that is not activated, no more testing is needed. If it's activated, you need to look for both autoimmune and alloimmune causes, and you'll find that outlined in my article that I told you about, that I posted in May of 2011. Heather Sump writes, what about normal, perfect-looking embryos via a young, healthy egg donor when the uterus looks great? In our case, we've used 3 egg donors with no success. My dear, all I can say to you again is what I've said to Kadena. When that happens with good-looking embryos from a young donor, if they are blastocysts that were transferred, you've got to be thinking of an implantation problem, and very often immunologic. And you're going to find doctors who will say to you, maybe your doctor will say, I don't believe it. I don't know how to answer that question except to say to you, find someone who feels that they will, because in my opinion, that's probably where your problem lies. One last point. Because an embryo looks normal, I've told you, does not mean it is normal. It could still be chromosomally abnormal. Let me give you a little formula. If an embryo is a perfect-looking blastocyst on day 5 or 6, in a young woman under 35, under 34, 1 in 2 of those will be normal. And those that are normal, if the uterus is receptive, should each have a 70% or 60% chance of propagating a baby. So if you put in 2 embryos that look good, there should be better than a 60% chance of a baby being born each time. And if it's not, think about the soil. Think about implantation. Olga Komodina writes, would testing testosterone levels indicate whether there may be problems with the maturation of eggs once HCG is injected? At which point the cycle would be at which point would it be tested? There is very little value in measuring blood testosterone. Think of the analogy. If I tell you to take a bucket of red paint, pour it into a canal, Olga, look where you're pouring it in, it'll be stained, but go 100 yards down and you won't even know that it was poured in, it'll be so diluted. That's the difference you see when you look at the testosterone levels as it's produced in the ovary as compared to when you draw it in the arm, the analogy 100 yards down. The levels are so diluted and they're 10 times probably greater in the ovary. So the problem is that if you've got high testosterone levels, it won't necessarily show up in your blood. You've got to suspect it based upon the history and the circumstances. Can dexamethasone impact egg quality during a cycle? No, I don't think it does. I don't think it has any adverse effect. And I would go so far as to say, based upon our own experience and results, we certainly do not see an adverse effect of dexamethasone on eggs. Ashley Strauss, can eggs with elastic membranes that were damaged upon ICSI actually be eggs with too much testosterone? Hell, Ashley, I wish I could answer your question. I just don't know. I don't know how the effect on the eggs will manifest and the various ways it can. Possibly, I mean, I just don't know, but I don't think so. The next one comes from, where's the next one? Olga Komodina again. Is there a published study that says that 90% of embryos that don't make it to blast in the lab will not make it anyway? Yes. You can look at our paper that we published, I think, in 2007 in Human Reproduction. In that paper, we looked at, I don't remember how many embryos, it could have been up to more than 100, I'm sure. And we followed them from the egg, where we biopsied the polar body on the egg and did CGH to test its chromosomal integrity. Then we serially biopsied the embryos every 2 days after that. Again, to make sure, and these were embryos that we then, at the end, when they made blastocyst, we then donated them to patients who wanted them and did it free of charge. We found that if the embryo came from an egg that was normal, it had a 97%, if the egg was normal, the polar body, and the man was fertile, there was a 97% chance, and I'm speaking under correction, of the embryos being normal, and on day 3 being normal, and then the blastocyst being normal. Whereas if the embryo was, if the embryo didn't make it to blastocyst, and we went back to look at the eggs and the embryos of origin, we'd find usually both of them were chromosomally abnormal. This is published data, and it's in our paper that we published in Human Reproduction. And then there is Cadena. If an embryo is not a blastocyst by day 5, is it still okay? I would give it to day 6. If by day 5 it's a morula, that means it looks like a mulberry with so many cells, and it's starting to blastulate, a little cavity is developing in the middle, I would give it another day, and then if it makes it by day 6 to the expanded blastocyst stage, such an embryo has got an excellent chance still of making a baby. How do you determine which day to conduct the CGH testing? Melissa, you may recall me saying that I don't mind whether you do your CGH testing on day 3 or on day 5, as long as you do metaphase CGH on day 3 and array CGH on day 5. You can also do metaphase on day 5, but if the embryo is normal on day 3 or day 5 by metaphase or array on day 5 or 6, then you're fine. But what I don't personally, in my opinion, condone is doing array CGH on day 3 embryos simply to have the results ready in time to put the embryo back in the same cycle as a fresh embryo. Is PCR different to CGH? Olga, you raise a very, very interesting comment. I don't say that CGH is the only way we're going to test the chromosomes in embryos. There are going to be new methods. It's possible that PCR is going to be the method in the future. There needs to be more data to convince me of that still. But if and when PCR is proven to be better than CGH, we will move from CGH to PCR, or whatever method comes up, whatever method proves to be valuable and reliable. Michelle Marie, which has more inconclusive results, metaphase or array? About the same. They're about the same, Michelle. There's no difference, except we do metaphase CGH on day 3, and array CGH is done on day 5 or 6 embryos, ideally. Christina asks, is the cost of a metaphase CGH per embryo or just one fee per cycle? It's one fee per cycle, by and large, so that we don't charge for the biopsy of the embryo on day 3. So there's no additional cost. When we do metaphase CGH, we don't charge for the biopsy, so that the patient isn't saddled with an additional cost if none make it to blastocyst. And then we send all of those that make it to blastocyst away for one test of metaphase on all, and we have the results back within 2 weeks or 3 weeks at the latest, allowing us to put the embryos back in the next cycle. Nicole Gates, do other fertility centers also do CGH testing? I'll say it's taken off like wildfire. There are programs even here in Las Vegas that do all their IVF by CGH. They won't even do IVF if they don't do CGH. To my way of thinking, that's going to the other extreme. I don't think that's justified. I don't think everyone needs CGH. I think it's for specific indications, mainly when there's unexplained embryo failure or when the woman is older and you want to bank embryos over several cycles and keep only the CGH normal ones to stop the biological clock and give the woman a chance to have a baby rather than go to egg donation. Why would you transfer 2 versus 1 embryo? Usually the patient's decision. I'm perfectly happy to transfer 1 embryo, and I'd say that I transfer 1 embryo almost half the time. But most patients, no matter what you say to them, don't quite realize that even twins carries a greater risk than a singleton, and they will request that you put at least 2. Many will request you put more than 2, but that's where we draw the line, and we don't go beyond 2. And if we force 2, then the patient really is asked to sign a release form. Olga writes, which embryo culture medium do you feel is best for growing to blastocyst? Can the brand used affect the number of embryos that grow to blastocyst? I know that there are many types of media we use, and I'm not an embryologist, and so I'm not going to sit here and comment on the various media. I think it's above my pay grade, and it certainly is outside of my scope of expertise. But I know that our embryologists believe that the media that they are using gives them the best results, and they've tried many. I'm not even sure what they use, to be very frank with you. I apologize. I've had a previous normal sonohystogram and HSG. Would repeat sono be recommended before starting new treatment? I've had an ectopic pregnancy since the original HSG, no tube removal. Christina, I can tell you that if you've had a sonohystogram within the preceding year that was normal, it's really necessary to do another one, unless there's some medical reason that suggests you may still be at risk. Are there negative side effects to vaginal Viagra? No, Christina, to my knowledge, and we've been using it now for 10 years, I've never seen a complication from vaginal Viagra. It's absorbed through the vagina, and it passes through the uterus. By the time it gets into the blood system, it's of a much lower concentration. The highest concentration is in the uterine wall where you want it, but in the blood the levels are very, very low, and I don't think there's any real risk for vaginal Viagra. Now, oral Viagra, that may be a different matter, and certain people who've got coronary vascular disease and other problems shouldn't be using oral Viagra. But we do not, and we have not seen problems with the vaginal Viagra suppositories. Do you routinely test for basal endometrial damage during an endometrial biopsy? You don't need an endometrial biopsy to tell you an endometrium is normal. If it's better than 9 millimeters on the day of normal ovulation, or around the time of normal ovulation, or after stimulation, or after estrogen, that's enough. But if the lining is continuously abnormal, even with estrogen and even in the regular cycle, then in some cases, although I don't think there's much place for it, you can do a hysteroscopy and biopsy to have a look and see how deep and how severe that damage is. Does a virus like shingles, says Kadina, cause natural killer cells? Not to my knowledge, Kadina. Brittany Donahoe asks, I was diagnosed with borderline positive natural killer cells along with my endometriosis and hypothyroidism. What is the success rate of those who have intralipid treatments to counteract this? Without knowing the results, Brittany, I couldn't comment. I look at the native state K562 target cell results. If it's above 10%, I consider that to be abnormal. In other situations, I call borderline when it's normal in the native state, but when you then add interleukin 2 to the mix, it becomes abnormal above 10.5%. Then that's borderline. In my way of thinking, if you have both endometriosis and you have hypothyroidism and you're tested and found to have anti-thyroid antibodies, boy, I would definitely treat that with intralipid. There's no downside, and it's not expensive or risky. Christina, for out-of-state patients, can intralipids be administered at a local hospital? I'll tell you how simple it is, Christina. Right here in Las Vegas, Walgreens infuses the intralipid on our patients. They do it the cheapest. They do it with patients as they wait in a waiting room. It's harmless, and there are very, very few contraindications. Some of them there are, but we look for them. But by and large, I've never seen a complication with intralipid, although I'm sure somewhere along the line something will come up. Michelle Marie, do you think CGH testing will be a standard in all IVF programs? It should be a standard in all IVF programs now, but not for all patients, Michelle. Only for those who need it. And as I said, I restrict it to the older woman who is running out of time and wants to get good embryos to bank over several cycles and avoid having to use an egg donor down the line. I also do it in older women who tell me, I'm running out of time, I'm making less eggs, I'm worried about my ovarian reserve, and so I want to have more than one baby. Well, obviously, if you get pregnant with a diminished reserve and you have one baby, by the time you've gone through the pregnancy, gotten ready for another IVF and breastfed and do all those things, a few years have passed and you're probably not going to be able to have another one. So embryo banking is a very, very important and useful tool. Embryo stockpiling of CGH normal embryos so that the ones you're keeping are good ones. Again, each CGH normal embryo by metaphase CGH day 3 or by array CGH day 5 should, if transferred to a receptive or healthy normal uterus, propagate a live viable pregnancy in about 60% plus of the cases. Nicole Gates says, my fertility center tells me to take an aspirin following transfer and until the test. Is this something I should do? Nicole, I can't tell you not to do what your doctor tells you to do. I don't do it. Is it going to do harm if you take it after the transfer's been done? Probably not. Is it going to do any good? I don't think so. But you've got to listen to what your doctor tells you in that regard. Kjo says, hello, would you tell us what's involved in testing for autoimmune diseases? A biopsy? Is it medication? Well, it's a blood test. And you ask for first a K562 target cell test, which looks for the activation of uterine natural killer cells. You also get an antiphospholipid antibody profile, and that can be done, but it's got to be done by the right laboratory. You can get what we call an immunophenotype, which looks at all the lymphocytes and tells you which percentage of what is there. And you can get antithyroid antibodies, of which there are different varieties tested for. And then you and your partner can both be tested for the alloimmune similarities, which involve matching of genes called DQ alpha and HLA. But that's the whole gamut. And as I said, in most of my experience, doing a simple test for natural killer cells is the start. If that is positive, then you can go further and look at all the other things. But if it's negative, I don't think there's a need to do more. But again, let me emphasize, you've got to go to the right laboratory. The two that I prefer in the United States, and there are about 4 that do this, the two I prefer are ReproSource in Boston, Massachusetts, and Reproductive Immunology Associates in Van Nuys, California, in Simi Valley. I think those are the two best ones in the country. There are a few more that do it, but those are my preferences, and that's where I send my tests. The next one says, can you test for immunity issues before doing another IVF for a candidate who's been through 2 IVF cycles and has unexplained infertility? Not only, in my opinion, Ruth, can you do it, I think you have to do it. Why would you go into another cycle if there's the possibility of there being a rejection of that embryo because of an immunologic issue? And you'll hear doctors telling you they don't believe it. That's like saying you could plant a seed on bedrock and it should grow just as well if it's a good seed. The answer is, it could easily be an immunologic or an anatomical implantation dysfunction, and it needs to be addressed. Always, if you have no explanation for failure, you've got to look at the possible reasons you could fail. And remember, when I started my talk, I told you it's the variables that affect the quality of the embryo, its competency, in other words, its ability to propagate a baby, and the variables that affect implantation. And those, although there are many, are primarily anatomical, immunologic. Nicole Gates asks, why would a fertility center transfer 3-day embryos rather than day 5? Nicole, that's a question I'm trying to ask myself. I have no idea, especially since, because there are many doctors that still believe, and I believe erroneously, that if an embryo is put back earlier, it's better off in the uterus than in the incubator. And if your laboratory is good, we have shown that that is not the case. An embryo that doesn't make it that is abnormal and doesn't make it to blastocyst is not one you would have wanted anyway. I've had 2 ectopic pregnancies, says Nicole, and 4 early miscarriages, 2 of which were IVF, natural cycles and frozen. What advice can you give me? I have had 1 successful fresh IVF cycle. Nicole, that's a tough one. I can only tell you this. Remember, I told you earlier on that I wasn't going to talk about alloimmune implantation dysfunction. Well, I'm not going to talk about it, except to say that with this type of immunologic problem, it's very common to have people come to you having had a baby, and sometimes even 2 babies, and then they start miscarrying or not getting pregnant because of the problem. So simply because you've had a successful pregnancy does not mean that you don't have an alloimmune implantation problem. and that should be tested for, in my opinion. Teresa, IVF journey. My RE doesn't believe in immune tissue testing. He refuses to do it because he believes natural killer cells are not a big issue. Well, Teresa, I don't mean to be arrogant, but all I can say to you is ask your doctor 2 questions. First, say to your doctor, explain to me what you understand by natural killer cells, where they come from, how they act, and tell me what it is you don't believe. And you'll find that in most cases, the doctor who says this is saying it without having a reason, without knowing, because he doesn't understand what it's all about. The area of immunology is a larger area than IVF itself. Many doctors are not interested in involving themselves in this area, and they just pay lip service often to what they hear other people say, and the other people have often got a political agenda. So I don't know what to tell you, except that if someone says to me, I'm not doing it because I don't believe it, my next question is, okay, let's talk. Explain to me what it is you don't believe and why you don't believe it. And then I need a reasonable explanation. If he can't tell me why he doesn't believe it, then I wouldn't pay much attention to that opinion. The next one is Letitia Preston Goering. I've just completed my 2nd failed IVF in St. Louis at SRM. Wow. Our last cycle, as you saw on the board, our first betas, and granted that is not the final story, we know that that 15 to 20% of pregnancies that were positive at the first beta will still be lost, but yet 83% of the women we transferred had a positive first beta, so I'm very sorry you didn't get pregnant. You were diagnosed with activated natural killer cells. You received intralipid in both. In both cases, we were told that our embryos were what? Does it go on somewhere? Well, I guess you said that your embryos were good because that's what this talk is about. I would want to know whether you were tested, even in my own center in St. Louis. I'd want to know whether they tested you not only for natural killer cells, but also when it was positive for alloimmune causes. Because one of the reasons why activated natural killer cell treatment doesn't work in some is because the doctor didn't take it further and look for the rarer variety called alloimmune implantation dysfunction, where you and your husband would match with regard to DQ alpha or HLA. That requires a totally different approach and a different bit of explaining and discussion, because it's not easy to solve that problem. So why don't you call me? If you're in St. Louis, give me a call and let's look through your records together. I'm going to be there next Monday, not this Monday, but the Monday following. Feel free to give a call and come in and talk to me or talk via Skype, and we'll see if we can find a reason why that happened to you. It shouldn't. Nicole Gates, would PCOS cause lining to be greater than 9 millimeters? Not to be greater than 9 millimeters. Absolutely, Nicole. Absolutely, and here's the reason why. You remember me telling you earlier on that people with PCOS often have overgrowth of the stroma of the connective tissue in the ovary that produces testosterone. When there's an overproduction of testosterone, it filters over into the uterus, and that reduces the ability of the lining of the uterus to respond to estrogen. So you stimulate the woman, the estrogen's high, but the lining doesn't get thick. And so the treatment is that if you're doing another fresh cycle, you've got to downregulate the LH for a longer period of time. And if not, take the eggs, make the embryos, and come back in a frozen embryo transfer cycle when you'll be able to deal with the issue of the lining being, of there being too much testosterone by suppression, and you'll get a better lining with a frozen embryo transfer. Where am I? Heather Sump. Could there be a sperm issue if only 2 out of 4 made it out of the unfreezing process with using donor eggs in one cycle, and in a separate cycle only 2 fertilized out of 11? Yes, there could, but I'd want to be sure that the method used for freezing was the right method, namely that they froze them through vitrification. In my opinion, if you vitrified blastocysts, let me emphasize, vitrifying blastocysts, day 5 or day 6, 95% of those should survive the freeze-thaw. And if they don't, either the freezing method wasn't right or they weren't blastocysts. I'm not sure, but I don't think a sperm factor would have played a role there. Melissa Horton writes, how often do you see a blighted ovum after successful IVF? Does a blighted ovum mean a bad quality, poor bad quality? The answer to the question is because the commonest cause of miscarriage is embryo related. Most blighted ova, where the sac is empty and there's no baby in it and no conceptus, are due to embryo causes. But it can just as easily be due to an implantation problem where the embryo was normal, but the nutrition of that embryo as it was trying to burrow and grow into the wall of the uterus was inadequate. So you can get a blighted ovum either because of an embryo cause, the most common, or because of an implantation problem, which can be anatomical or immunologic. Nicole Gates writes, do changes of pregnancy, do the chances of pregnancy increase with additional embryos transferred? Not in my opinion. I think when you go above 2, all you're doing is increasing the risk of multiples. I don't think there's any justification for going above 2, and frankly, if it's CGH tested embryos, 1 should be enough. Annette M. Astorino writes, how would I know if my body has problems with implantation? Well, if you're getting good embryos and you know them to be good by CGH testing, or you're young enough that 1 in 2 should be normal, and you're not getting pregnant over and over, if it's not the seed, what? It has to be the soil. So you know by a process of elimination that if good embryos are getting into your uterus and you're not getting pregnant, you've got to focus on implantation. Thank you, Christina, for your kind remarks. Brittany Donahoe, would having a second laparoscopy before IVF help our chances of a successful pregnancy or live birth? No. There's no point in doing laparoscopy unless you're doing it for the purpose of freeing adhesions, removing a tube that's distended with fluid called a hydrosalpinx, or taking out an ovarian cyst or an endometrioma. Otherwise, there's really no reason to do a laparoscopy. Thank you, Christina, again for your kind comments. Thank you also, Brittany. I appreciate it. Harini says, I had 2 fresh and 1 frozen transfer for IVF cycle, but all failed, unfortunately. Do you think I should do an endometrial biopsy to check why the good embryos are not implanting? Harini, let me say this again. Testing for natural killer cell activation does not require an endometrial sampling. There is a new test that's come out which I am very enthusiastic about because I have a feeling it's going to prove to be even better than doing the K562 blood test, and that is endometrial sampling for Th1 cytokines. This test is already being used, and I'm already matching the K562 tests for natural killer cells in the blood with the endometrial sampling for cytokines, and they seem to match. So I'm very optimistic that down the line we'll be able to diagnose natural killer cell activity in the uterus just as easily through a simple sampling of the endometrium for cytokines. But I think that an endometrial biopsy itself is of no value to you if you've got a thick enough lining. All you need to know is, do you have natural killer cell activation as well? Nitin Carthy. But just before I get to you, let me say to everyone again, I'm so impressed and appreciative of how many of you have joined this session. This is one of our largest sessions, and I'm going to keep doing them every 6 to 8 weeks. But I want to say again, all you need to do if you want to talk to me via Skype, I emphasize, is pick up the phone and call 1-800-780-7437. That's 1-800-780-7437, and set up a consultation via Skype, and we can go over your problems in detail, and then you can decide what to do. Alternatively, please go to the blog ivfauthority.com and go to the discussion, the comment section, and read the articles and write down any questions or comments that you might have, or go to the discussion board on haveababy.com. Haveababy.com, and post your questions there. I'm considering doing, where are we now? How do you treat 50% DQ alpha matches? Anything else besides intralipid and prednisone? Nothing else, But I don't want to go into detail here, Melania. You'll need to go read this up on the blog. It's going to take too long. But we put back single embryos at a time. And when we put back, it's my opinion, that you need to put back single embryos at a time, and that if you put back more than one, and the one matches and the other doesn't, the matching one can activate natural killer cells and make it worse for both. So you have to put back one at a time, and what I do is I continue the intralipid infusion way beyond the positive beta HCG test. I take it all the way through to the 24th week of pregnancy. Annette M. Astorino says, I had 3 A-grade embryos. Is there a way to check my body for implanting issues? Also, is there anything I could do to improve the chances? Annette, again, I've already gone through this. You can check for anatomical and immunologic causes. Again, the anatomical, the thickness of the lining on the day you ovulate normally, or around the time of ovulation, or after being stimulated for a week or longer for IVF. You should have a lining measuring more than 8 and preferably more than 9 millimeters with a trilaminar appearance. And you can also have a test done before you do IVF, a sonohysterogram, to look for surface lesions, and then you can do the immune tests I've referred to several times. Kim K. Joe says, I'm considering doing an endometrial function test. Okay, by all means, go ahead and do it if you feel you want to. I don't want to, I know Harvey Klein very well. He's a smart and extremely good doctor. I'm not a protagonist or very much a believer in the type of endometrial functioning test you're talking about, but others are, so you have to make your own decision in that regard. Teresa, IVF journey, my lining has been 15 and 16 millimeters. There's no such thing as a too thick lining, Teresa, as long as it's not pathological, malignant or hyperplasia. But if it's a normal lining that's thick, there's no problem with that. K. Joe, I recently did an IVF where we froze 3 embryos on day 3. Is it reasonable to thaw them and wait until they reach blastocyst stage to transfer? Eureka! Hallelujah! Common sense. Take it to blastocyst, refreeze it, and then put it to transfer, or thaw it and take it to blastocyst and transfer on the day corresponding to your day 5 embryo, which is 5 or 6 days after progesterone in an FET cycle. Michelle Maria, I'm sorry I missed you. Can things like PCS go undiagnosed even after infertility treatments? Unfortunately and regrettably, yes, it can. Melania List, do you think a scratch test? I'm very well aware of the scratch test before implanting embryos. I'm not a believer. It was tested in our program in Manhattan, in New York, and we haven't seen any benefit from it. I don't use it. Letitia Preston Goering, you guessed correctly. The last half of the question. I will check with Amy tomorrow if I was tested for autoimmune issues. Would this testing be your next? Absolutely. Letitia, if you had natural killer cell activation and you've had repeatedly good embryos put into your uterus and you've not had a DQ alpha HLA test, you owe me a beer when it comes up positive. Melissa Horton, I still have 2 frozen blasts in St. Louis because I have had the blighted ovum. With these last 2 blasts be bad quality? No, depending upon when they were were frozen. If we froze them in the last 5 or 6 years, then they will be as good as the day we froze them because they were vitrified. Melissa Horton, I've done that, right? K. Joe, as a Canadian resident, must I travel to the clinic in Boston or California for the testing? No, K. Joe. You can send your blood and have it sent there for the testing. All you have to do is call them. They've got 800 number. Look it up on Google and call them and tell them you want to do the test and ask your doctor to order it. Jesse, how many failed attempts need to occur before further testing should be done? Hey, Jesse, 1 unexplained failed attempt without an explanation warrants testing before you do it again, don't you think? I really think that the moment that nobody can give you an adequate explanation as to why you failed that satisfies you, you should be able to demand and expect a more detailed evaluation. Then comes Ruth Watton. Do you do uterine scratching? I don't use it, as I said earlier, Ruth. What is your opinion on embryo glue? Again, it was first introduced by a guy called Feichtinger in Austria in the late 80s, early 90s. He was a very good friend of mine who's since retired. Feichtinger dropped the approach because it didn't work, as I recall, and I don't believe embryo glue has the slightest benefit whatsoever in IVF. The mechanism of successful implantation has to do with an embryo having the capacity to develop its root system properly. In other words, it has to be chromosomally normal, and a uterus that is receptive because it's not rejecting the embryo, and that's the anatomical and immunologic assessments I mentioned earlier. Thank you, Nicole. I appreciate your kind words. Harini, is endometrial sampling and EFT test the same? Yes, except that you can do endometrial sampling not for EFT, for embryo function tests, but for cytokine sampling, and as I told you, I hold out a lot of hope for that option. That kind of winds us up, folks, and again, thank you all so very, very, very much for taking time out to sit and listen to me for an hour and a half. I hope you found it to be beneficial, and I will be having some more of these webinars on topics that I think are important, and I promise you that it'll be posted on our website, and you'll know about it well in advance. Again, be sure that you feel comfortable. Should you want to talk to me, to call 800-780-7437 to set up a Skype consultation with me. Glad most of you liked it, and thank you all, Christina, Nicole, Annette, Olga, for all your kind remarks. You're very, very kind people. Thank you, Arini. I'm going to go now. Have a wonderful, wonderful evening. God bless.